Well, welcome everyone to today's webinar exploring what the four UK nations might learn from each other on health policy. It's the first of a series organised by the Campaign for Social Science on the topic of devolution. Um, those of you watching the news on Sunday night will have seen the debate between uh, the six male leaders of political parties in Scotland. Uh, their elections are imminent, so are the Welsh. Stormont elections due next year, and legislation on devolution is working its way through the kind of the National Union Parliament. But what I want to do is to showcase social science perspectives and insights which can help to make sense of the key issues. And what I think what we want to do with this is to uh, not say why are things different with England as a kind of the exemplar of the way things should be done, but rather turn that on its head. Of course, things are different. That's the point of devolution. And the people of Scotland, Wales, and Northern Ireland have asked for decisions to be made closer to home by elected representatives who better understand their nation's needs. And that will inevitably mean that different priorities are set, different decisions are taken, and different outcomes are experienced. So, what we want to understand with this series is what has worked, what hasn't, what might be replicable elsewhere, and why some policies won't translate to other parts of the UK. There's incredible potential for the governments of the four UK nations to learn from each other, to be crucibles of policy innovation. For the last 27 years, have only seen them happen kind of patchily, to say the least. So we want to know what might be the areas over the next term of the Scottish Parliament, the Senate, and the Northern Ireland Assembly, where the devolved government strike out, do things differently, and come up with bold ideas which might transform how other nations and regions approach things. And actually, I think it's important to kind of nationally, as the deval, because it's becoming obvious to everybody that kind of that the trend within England is towards more devolution. So, kind of, what can Manchester or London and other devolved authorities within England learn from this process? So, let's start the discussion with a spotlight on health. And we're delighted to be hosting today's webinar in partnership with our friends at the Social Policy Association. And we've got four excellent panelists that are on your screen ahead of you. There's Ellen Stewart, Professor of Public Policy at the University of Glasgow, Anne-Marie Gray, Professor of Social Policy at Ulster University, uh, Kate Checkland, Professor of Health Policy and Primary Care at the University of Manchester, and Lorelei Jones, Senior Lecturer at Healthcare Organisation at Bangor. What we're going to do is hear from all four in turn, then open it up to questions which you can submit via Zoom's Q&A feature. So let's no more ado from me. Let's kick off with Ellen from Scotland, social scientist working at the intersection of medical sociology and health policy, and previously co-director of the Centre for Health Policy at the University of Strathclyde.
Thank you so much. I'm tremendously grateful that the Academy has put together this event. I think, as Will gestured to in his introduction, we had such high hopes for the natural experiment of health policy learning across the UK at the point of political devolution. And that has certainly, in my view, not come to fruition. Some of that has been about the political incentives of different governments not to learn from each other, but to rather crow about their own achievements in comparison to each other. But it does also seem to me something of a failure of our research ecosystem that we haven't made up for those political deficits in the learning that we've driven. So I hope this is the start of many more conversations. So I'm speaking from Scotland, where we are facing a big election. And in a lot of the run-up to that election, commentary has been about NHS performance. Is the NHS broken or not in Scotland? Broadly, I think if we were to take a somewhat superficial headline, there's a sense that Scottish NHS performance was holding up okay before the COVID pandemic, and comparing at that point quite favourably to some of the other health systems in the UK. I'm thinking about key measures such as A&E waiting times when I say that, but that Scotland's recovery from the pandemic has been slower than the other systems in the country, and that there isn't necessarily much of a sense that there's a clear plan for how we move forward from that position. So that's the headline, and then I'll dive in a bit to some areas of focus. So it's been quite a quiet quarter of a century in health policy terms in Scotland, especially if you compare it to the pace of reform and change and abolition south of the border. So I think if you're looking from the outside, there have been two moments of reform which are significant enough to really make much of a ripple, so anything to write home about. The first would be the abolition of the internal market in Scotland, which was actually a reform that began pre-devolution in the aftermath of the 97 Westminster election. And then more recently, in the 2010s, the SNP led health and social care integration. And internationally, they took quite a distinctive approach to that and mandated top-down legislative approach to health and social care integration, which contrasted with systems like the Netherlands, for example, where it's been much more relational and grassroots driven. Often we talk about the continuity in Scottish health policy as being a positive. There's a lot of money is wasted on reforms and reorganisations that we see south of the border. But in this presentation, I'm also going to point to some of the potential dysfunctions that have been left untouched by that tendency to continuity. So at the point when the internal market was rejected in Scotland, there was a real sense of avoiding any accusations that what was being returned to, that backward step, as this quote says, is a system of command and control, similar to what we saw in kind of 1974 reorganisations of the NHS. 2 years ago, I convened a witness seminar with some senior politicians and civil service leaders from the period. And Kevin Woods, a former NHS chief executive, talked about the idea of framing the approach that they were shaping as a partnership model, a partnership between health professionals and the state to deliver the best possible care to communities. And that's broadly continued in the intervening years, where I think there's been a change in atmosphere, perhaps, has been that I think this SNP has had a much more centralising tendency as a government over its now nearly 2 decades of control in Scotland. So the first quote here is from an article about health and social care integration, which identified competing accountabilities created by health and social care integration, keeping health boards ever more tightly constrained by central government, while local authorities, which hold the social care budgets, are kind of forced into collaboration locally. A really interesting article published last year by a colleague at the University of the West of Scotland, Meshkur, about the failure of implementation around the National Care Service, this really ambitious, exciting proposal, which is paused currently, is my understanding. And he said that this was, again, a sense of a government with a centralising tendency. If you want something done, just bring it to Edinburgh, colliding with the reality of needing to work locally and implement things. So I think to some extent you can say that SNP policy is much closer to a command and control model than those early visions of partnership in the first several terms of the Scottish Parliament. What that continuity has meant, though, is that we've had a very stable organisational structure. This is a map from 2017. It is broadly unchanged. These are the territorial boards, which Scotland is divvied up into, and within each of these regional areas, that organisation, the Health Board, plans, commissions, delivers all or the vast majority of healthcare to that population. There's a really dramatic difference in population size within these, and that relates to Scotland's very concentrated population in the central belt, where around 75% of the population lives, as opposed to the quite large and scattered landmass that you can see here. So NHS Shetland, for example, only serves a population of about 23,000. Greater Glasgow and Clyde, the largest of the health board, serves a population of over 1 million. And if you could look to the ICSs in England, which I know Kath will come on to talk about later, they're serving footprints of 300,000 to 1 million, approximately. So the health boards are small in population terms, although not always in geographical terms. Where SNP has driven reform, including health and social care integration, it's tended to do that by adding layers of governance rather than by reforming or reshaping at the local level. So this graphic taken from an Audit Scotland report shows some of these, and at the top is a new SNP aspiration to move towards regional planning of services and more sharing of services across health board areas. Significantly, what they aren't proposing is to my knowledge, in public at any rate, is a reduction of the number of territorial boards. So the idea is that they encourage boards to collaborate better and more effectively without reducing the number. If we look at the manifestos for the 2026 election, the Lib Dems still not published, which seems to me rather late, but nonetheless I've summarised some key points on structural reforms from the others here. Labour have come out with, I think, to use a non-academic term, frankly, a hectic manifesto of healthcare policy commitments, including reducing the number of territorial boards down to 3. Quite a dramatic potential shift there. So there's continuities there, but again, we see this pattern of the SNP adding layers of governance rather than reducing at any point. There's different views on whether that's a good thing or a bad thing. There's a lot of expense, hassle, and political battles involved in reducing and merging boards, but nonetheless, it's starting to feel like reform without addressing the number of territorial boards starts to look a little empty, perhaps. There hasn't been very much talk about those structural reforms, despite the fact that they are present in the manifestos. And in the leaders' debate that Will mentioned earlier this week, it was notably absent to my mind. What we are talking about quite a lot is GP walk-in clinics, which I think is another example where we see a real lack of cross-national learning. As soon as I mentioned to Kath, who's going to speak shortly, that the SNP were proposing GP walk-in clinics, she said, well, that'll never work because we tried it in England. This was something that appeared in the budget trail last year from the SNP, and quite unusually for Scotland, it was met by criticism from the Royal College of GPs and from some other significant primary care voices in Scotland. So thinking back to that partnership model, it's very unusual in Scotland for a health policy to be kind of launched on the world without bringing the professionals with you. And that criticism, I think, points to something interesting about this policy. I think this is an attempt at a vote winner. It's all over SNP election materials. And I think it is speaking to a real problem. There is a genuine challenge around GP availability and access in Scotland. But I think this isn't the right policy solution. I think it's also not congruent with broader Scottish Government policy recently. So this was a series of documents that were published last year in a response to calls for reform of the NHS, which have been increasingly loud from organisations, especially from Audit Scotland. And the bottom document here is a renewal framework that is full of really laudable principles. And one of those principles, which will not come as a surprise to anyone familiar with health policy debates, is about preventing ill health, that the NHS needs to shift towards that. I think GP walk-in clinics speak to a really different vision of what healthcare is. It's kind of episodic, transactional, get in, get seen, get out again. And I think actually the evidence base around how primary care, strengthened, properly resourced primary care can support prevention of ill health is much more about relationality and continuity of care. So I think this, the walk-in clinics policy is an interesting one, and one which suggests perhaps a little bit of political pressure on policy making last year. So to sum up, if I can, so thinking about, we're all, full of election fever here in Scotland at the moment. And to my mind, the NHS has been everywhere and also nowhere in this debate. Every single manifesto has the NHS front and centre, fix the NHS, or in the SNP's case, stay on the same track of fixing the NHS. Reform had fixed the NHS as one of their 5 bullet points, and then no proposals for how they will actually do that, to my mind, contained within the manifesto. The debate has been high on arguments about performance and very low on any diagnosis of how to move forward. Within commentary and debate and analysis in the run-up to the election, I think we see a lot of discussion stuck in terms of what is quite easy to measure, what data can be pooled, especially perhaps by people assessing the Scottish NHS from London. So we see talk about budgets, about staffing numbers in the input side. We see discussion about outputs, activity levels in hospitals, waiting lists and where they're sitting at, waiting times rather. What we see much less of, and in my mind not enough of, is discussion about health organisation policy, about how we transform those inputs into the outputs, and even more important, the outcomes we want to see at population level. So I'm hoping that I'm going to be proved wrong, and in the last 2 weeks of this election campaign, we're going to see a real maturity of debate and many more substantive discussions on health policy. I'll leave it there. Thank you.
Thank you very much. Just in a sentence, is there satisfaction broadly amongst there's meant to be marginal increases in satisfaction in NHS England. Anything happening in Scotland on that along those lines?
So the British Social Attitude Survey, which is a wonderful resource for looking at satisfaction in England, the sample is too small in Scotland for it to be very meaningful. I think there are major problems around satisfaction. There's real anxieties around waiting times, particularly long waiting times in Scotland at the moment. So no, I don't think, and that was when I referenced this sort of sense of a slower recovery than other systems. I think we're not in the same place in that recovery trajectory as, for example, England, is my view.
Good. Kath, over to you, to Kath Checkland. Oh, no, sorry, beg your pardon. It's Anne-Marie. Anne-Marie. Marie Gray.
Hello, everyone. Thanks so much for coming along to the seminar today. Speaking from Northern Ireland, I have to say one of my greatest challenges was finding positive things to say about health policy developments, but actually I think there's been much more of a positive trajectory for the past year. So I did think it would be useful maybe to provide some context, because Northern Ireland has had a unique structure within the UK for quite a long time, well before devolution, since 1973, when we've had a fully integrated health and social care system. And at the time, that was actually an example of innovation from the civil service rather than from politicians. And I think one of the things which has impacted even our current health policy is the distance which our politicians have liked to keep from health policy making. I think I go on later to say that it's been one of the most unpopular ministerial portfolios in the Northern Ireland government. But post-devolution, Northern Ireland is also unique in terms of having a mandatory executive, a multi-party executive. So I think policy has been less obviously value-driven than in other parts of the UK. We've certainly had much less focus on the internal market and on competition, and that's partly to do with scale and size. We've had a continuing commitment to integration over that whole period, so there's been no political party or professional grouping advocating for that we shouldn't have a structural integration. There has also been consistent agreement across the various parties about the need to reform, particularly the acute care system, but there has been really very, very little progress on that. And in the history of devolution, there's been an extraordinary little focus on social care within this integrated system. We've, I think, increasingly moved towards a very strong degree of centralisation in the planning of services. And because local government has essentially, since 1973, not had any health and social care responsibilities, we have really had very weak opportunities for political participation and political engagement. And that's been, I think, partly contributes to the challenges that government has had in trying to implement some of the more fundamental reforms. Of course, as people will know, this hasn't been helped by the political instability in Northern Ireland. For 40% of the period of devolution, Northern Ireland has been without a government, and that has really impacted in terms of the traction needed for healthcare reform. We've not had multi-year budgets for some time. And I think there is an argument that healthcare efficiency has been sacrificed for political reasons and for reasons of populism. As Ellen was saying, certainly it's good to look at organisational reform, but there has really been so much organisational reform in Northern Ireland, but without really specifically being keenly linked to anticipated outputs. This is the structure at the moment. We have seen in the past 5 years greater centralisation, so powers being returned to the Department of Health and the abolition of what was a regional health and social care board. And that has resulted in more strategic direction and some more accountability, I think. We do have a considerable number of quangos for the size of the population, 1.8 million people. That's another legacy, I think, of our history. But probably good to draw attention to the 5 health and social care trusts, which are the planning and delivery vehicles for hospital and community services. The most recent organisational innovation, to call it that, will be the introduction of these new area integrated partnership boards, which are being argued to bring a level of localism to health policy in Northern Ireland, which hasn't previously existed. So we don't have an election this year. Our election is May 2027. But I think we can already see, certainly in terms of the health minister, that the consciousness of that this is top of the public agenda. I don't think it's top of the political agenda, but certainly it's something that strongly occupies the public and media narrative. Since 2000, various governments in Northern Ireland have commissioned external independent reviews, but none of those has been even partially implemented. We have certainly had a preoccupation with structural reform, but not in terms of the radical transformation. There has been innovation. So since 2016 particularly, there's been a transformation strategy and transformation funding. That's been mostly used to pilot ideas and to pilot initiatives. Some of those have been really successful and have been evaluated as so, but there's been a major challenge upscaling. So one example would be the idea that all of the GP federations would consist of multidisciplinary teams. One has for some years, 3 have partially. The outcomes are very, very positive. Patient satisfaction is very positive, but it's been a real struggle to extend that to the full 17. So that's all in the context of very long waiting lists, the worst in the UK, 500,000 people currently waiting for a consultant appointment, workforce recruitment challenges, low public trust, and the collapse of general surgery in some hospitals due to the lack of transformation of that acute sector. However, just in the past few months, there has been a kind of energy coming from the Department of Health. They've published a reforming adult social care strategy, which has been kind of cooking for the past 10 years. It's a 10-year strategy, but importantly, with a 3-year delivery plan attached to that. There's a new document looking at really explaining why the hospital system needs to be reformed in a way that has never been explained to the public before. So there's a recognition that there has to be more public engagement and public buy-in. And both of those documents are really focusing on new neighbourhood models of care, really trying to see how the best potential could be achieved from integration. And also some innovation in social care commissioning linked to digital developments, with the trusts taking much more of a lead in that rather than the private sector. And that has resulted in the trust that's being done, far fewer people waiting for care and in savings as well. So 1 year to the election, we're seeing this kind of reset plan. We're seeing money being pushed into waiting list initiatives, especially for people waiting 4 more years. That's had some fairly immediate success, but it's quite a short-term thing. We are seeing some policy focus on maximising those integration opportunities through more collaboration and through more localisation. We've just completed a digital modernisation, the Encompass model. So all of the health and social care trusts are now under one digital system with a single digital record for every citizen. And this is really the first thing that the trusts have done in common. There's been a real problem of the trusts being quite autonomous in terms of their data collection and their policy implementation and so on. And that's certainly been driven by part of the stronger strategic insight at departmental level. And then a more pragmatic approach in terms of testing what works, but actually taking forward some of those lessons. So just in terms then of reflections, I think we do have the longest structural integration in the UK. The advantages are not as clear as one might think. I think just to finish on the political challenges, health is not a popular department. The health minister since 2020 has been a minority minister. Both major parties want to distance themselves from any bad news around health outcomes and health policy. One example of that is just a recent decision based on learning from Scotland to try and push through legislation on minimum alcohol pricing, which was blocked by one of the major political parties on the grounds that it wasn't something the Department of Health could decide, but something that should come to the entire executive and therefore, will not be implemented in this mandate. So thank you very much.
Slightly depressing the painting, actually. So, Kath, with no more ado, let's come to you. Not only a social scientist, but a qualified doctor. Kath, over to you.
Thanks very much. So when I was asked to do this, I must admit, my first reaction was one of slight horror, because in comparison with Scotland, we have what we call in England hyperactive policy making, and I think one of my colleagues who might possibly be on the call is actually thinking about writing at the moment about hyperactive policy in England, and that does make it quite difficult to sum up 20 years of policy in 10 minutes. So I'm going to focus on two things, I think, which are quite distinct from the other nations. And one is the kind of outsourcing and then re-insourcing of executive control of the NHS to NHS England, which is framed around politicisation and depoliticisation. And then I'm also going to talk about the persistence of the purchaser provider split and have a little bit of a talk about marketisation and whether it actually means competition or not. So this is a very selected timeline. It's not really everything that's happened at all. But I think one of the things that I've tried to highlight here is the kind of waxing and waning of the focus put on competition. 2012 obviously stands out as a very big moment with the Lansley reforms, a really big focus on competition. New Labour declared the end of the internal market in 1997, but actually reintroduced it by the back door in the early 2000s around the notion of choice. The 2012 Act put European competition law, made the NHS subject to European competition law, which is a big deal because it means that the NHS can be taken to court and has been for not being competitive enough. Then we had the 5-year forward view, which put the emphasis squarely on collaboration, not competition. 2022 Act kind of consolidated that with a duty to collaborate. And then in 2025, we've now got the 10-year health plan, which is going back to strategic commissioning with a view, with a suggestion that maybe more competition. So we've had this really we created integrated care partnerships in 2022 and then we got rid of them in 2025, which I have to say is probably the fastest sort of creation to abolition of an NHS structure that I've ever seen. Yeah. So just very briefly on NHS England, so created in 2012. And I think the thing I'd like to focus on here is the kind of description as to why we had to have NHS England. And it was very clearly described as a mechanism to reduce what was framed as political interference in the NHS. It was going to be lean, it was going to be expert, and it was going to allow the development of transparent objectives combined with local clinical autonomy. And it was very clearly not to be the headquarters of the NHS. This was stated. It very quickly became the headquarters of the NHS. Simon Stevens, he was a second chief executive, was universally referred to as the chief executive of the NHS, in spite of the fact that was technically not correct. And his 5-year, and he performed that role. His 5-year forward view, which literally was his, and I understand that he more or less wrote most of it. And it downgraded the importance of competition in favour of collaboration. So it was really quite the antithesis, actually, of the 2012 Act. This was only 3 years later. What was interesting about this was, of course, that accountability became quite unclear because we had NHS England making policy, despite that not being their role. So we fast forward to the abolition of NHS England, and it really did come somewhat out of the blue. We kind of expected it to the extent that what we all thought would happen was that the roles of NHS England and the Department of Health and Social Care would come more closely together, and that they would sort of start sharing portfolios, and it would sort of, the abolition would happen over time in a sort of slow and managed way. What actually happened was that the Prime Minister announced it in a speech, and Wes Streeting has since confirmed that it was discussed with virtually no one beyond the very top of NHS England. The argument made is the mirror image of the argument that was made when NHS England was created, and I think this is what's really interesting. So there's a lot of talk about duplication, and that NHS England and Department of Health and Social Care were man-marking one another with associated excess reporting requirements. Trusts were reporting to both NHS England and the HSC. It's framed as being the abolition of the largest quango in the world, which is clearly a good thing. We like abolishing quangos, and it's going to be leaner. Which is really interesting, that the lean word is something that keeps recurring. So NHS England was created to be lean, sort of oversight of the NHS, and now we're going to be lean by getting rid of it. But also it's about improving political accountability. And I think this raises some interesting questions across nations, which is what is the appropriate level of politicisation of the NHS. So Anne-Marie has talked about sort of politics being a problem in Northern Ireland, and I think in Scotland you've had that kind of stability with it not really being a political football. And I also think there's some interesting questions about to what extent does an NHS need an executive function, and how is that executive function provided? I think it's pretty clear that the way the abolition has been approached has been quite destabilising. And I think the notion of leanness is a really interesting one, because I think most commentators would agree that the NHS is significantly undermanaged compared with international health systems. And I'd be interested, I don't know what the comparison is between management in England and Scotland, Ireland and Wales. But I think the idea that getting rid of managers is somehow going to make everything marvellous is potentially problematic. Now, just to come on to the purchaser-provider split, because I think this is something, so Ellen mentioned the sort of abolition of the internal market. And it's easy to caricature England as being, well, it's where we do competition, we do marketisation, but I think there's a lot of nuance in there. So we've abolished it, and then we've reinvigorated competition around the notion of choice. We kind of turbocharged it with the application of European competition law to the NHS. But we then almost immediately downgraded it again in 2014, 2015 in favour of collaboration and integration, although that was really quite difficult because competition law still applied. Then the legislation in 2022 disapplied competition law again and mandated collaboration. But then the 10-year plan is bringing back strategic commissioning and possibly, we're not entirely sure about this, the use of competitively awarded contracts to facilitate integration. So rather than it being, well, England does competition, the other nations don't, I think the extent to which we do competition has fluctuated, or we rhetorically talk about competition has fluctuated quite significantly. And I think what's interesting is to tease that out actually a little bit. And I think this is a fundamental difference between England and the other nations. And I think it's really useful and interesting to interrogate this a bit more, because the fundamental mechanism underlying provision in England is contracts between purchasers and providers. But that doesn't necessarily mean competition, because you can have a single preferred provider. You do not have to have competition if you have contracts. And I think that it's really interesting that in England, we've never got rid of contracts. We've talked a lot about doing better integration and collaboration. And in 2022, when they brought in the 2022 Act, they could have got rid of contracts at that point. They could have said, no, we're going to go for a more managed approach to support collaboration. But we didn't. We stuck with contracts as a delivery mechanism. And I think there's a number of reasons for that. I think one is that it does allow greater transparency and better accounting for what's being delivered by whom. There's a potential for better financial and quality management because there's a much greater clarity over what's being provided by whom, to whom, at what quality. I also think there's something unstated about the power of large-scale NHS trusts, because in order to get rid of contracts, you've got to get rid of trusts, independent trusts. And I think probably the rhetorical idea of choice remains very powerful in England, partially driven by the internet age. This is just a quote from the IFS, and it's just highlighting the fact that contracts are very useful if you're wanting to monitor performance. And the IFS were making the point here that one of the problems with monitoring performance in Scotland is you've not got those detailed measurements of productivity because you haven't got contracts. And I think that's quite interesting. 10-year health plan, we're going to have more integration, but it's going to be delivered within a contract held by a trust. We're going to have neighbourhood health, similarly to Scotland, talking about and Ireland, talking about neighbourhoods, but we're going to do it within a contractual mechanism. And I think that brings up a really interesting point of comparison that we need to think about. So my brief canter through NHS policy is that I think all systems are prioritising greater collaboration and integration, without being clearly specific what that means. We're using a contractual approach and the other nations are not. And I think the power of NHS trusts in England is really important. So one of the things I think is it is easy to caricature the health systems that we're less familiar with. And I think people do caricature England as being, oh, England's where they do competition. And I think that it's much more nuanced than that. I think the overall performance is much less different than politicians would have us believe. And that's really interesting because that makes you think, well, actually, what's all this about? But systematic comparison between the systems has really been limited. But then, of course, the sheer size and complexity of the NHS in England makes those comparisons really difficult. So, sorry, that was really quick, but I'm sure there's lots of food for thought there.
Gosh, in 10 minutes, you've done bloody well. I can't. But I've got lots of questions I'd love to ask you, but I really think we should go on to Lorelei. Lorelei, where are you? I can't see you. You there?
Hi.
Yeah, very good.
Yeah. Okay. Diolch, Will. Prynawn da. Mae'n hyfryd bod yma. Good afternoon. It's lovely to be here. I'm going to talk a little bit about strengths and challenges of health policy in Wales, but what I really want to do is talk about learning from other nations. So you may have noticed already that I've got Welsh family, I've got Welsh speaking children, and I live in beautiful North Wales, but I grew up in Australia, and in fact, I spent most of my early part of my academic career doing ethnographic research in the NHS in England. So my perspective today is coming from a social science perspective, from an anthropological perspective, anthropological background, but also from my personal experience of working in both countries. So by way of introduction, I think Wales is rightly known for being world leading in its well-being of future generations legislation. So this is legislation that compels public bodies to ensure the social, the cultural, the economic and the environmental well-being of citizens, both now and in the future. One of the things I'm interested in is positive public policy. So this is the idea that we can learn from successful policy, and it's something I use in teaching. And I do find that, working in Wales, it does feel very creative and it does feel very optimistic. There's a distinctive political culture based on collaboration, based on democratic participation, and focused on prevention and well-being. And this is something that goes beyond rhetoric. It is something that you see in the way people work, and it's something that you feel. And there's a genuine interest in what academics are doing. So Welsh Government is interested in what academics are up to. Are they doing any interesting research? Are they doing anything that could improve the well-being of citizens? For example, I have a colleague, Kat Ford, who's been doing research on adverse childhood experiences. So these are things like problematic parental use of alcohol, problematic use of drugs, exposure to domestic violence and so forth. And her research looks at how this can influence childhood development, but also how children, when they get to school, they can do things that increases their resilience, so participate in sport. And this research has very quickly been adopted by policy. So there's a genuine interest in academic research, but I think more importantly, there is a genuine interest in policy debate and policy discussion. And this is just an example. So thinking about something that I'm quite concerned about is the financialisation of care homes. So this is opaque and complex ownership of care homes for older people and operating practices that are based on extracting value and on maximising profit. So research that has been done in Manchester has looked at how this impacts on quality of care. But this isn't what Mark Drakeford is saying here. What he's saying is that it's wrong. And I think this is important because I think, you know, to address the challenges of the future, it's not just about technical questions, it's about political questions and it's about ethical questions. And this is something that Wales has always embraced. So we do have challenges, and we've had challenges with secondary care. Waiting lists are starting to come down. They've come down to the lowest level in 6 years. But certainly where I live in North Wales, we have ongoing challenges with A&E waiting times, especially for patients who are waiting longer than 12 hours. This is something that concerns patients, it's something that concerns communities, and it's something that concerns staff. So when you have problems in A&E, the causes of these problems are capacity and flow. But the thing is, it's about capacity and flow across the entire system. So for example, you might find it difficult to discharge a patient if they don't have the appropriate care at home. And if you do discharge somebody when they don't have the right care at home, enough care at home, then they may end up being readmitted. So what government needs to do to support systems is to provide support for capacity, and they also need to provide support for systems to work together to do process mapping and to walk towards solutions to these problems. And in general, this is the way that Welsh Government is going, but it will be interesting now that there is a bit more political pressure to see whether that approach is maintained. I think one of the really positive things that is happening where I live in North Wales is around organisations working together to develop a new model of care for home care. And as I mentioned, you know, home care is absolutely, you know, the crux of issues in A&E. And what they're doing is they're looking at a model of care which, you know, really focuses on the patient, focuses on patient-centred care, and a holistic approach to looking after people. So thinking about people's families, people's communities and the resources that are available to them and how they become more independent. And it's looking at making the job more attractive. And this is a job I've done myself in my career. And it's really important that this work is more attractive, that it pays better, that it has better working conditions, that it's better shifts, more regular shifts, and that the work is more meaningful. But as you can see from what I've just said, there's an awful lot in there. You know, there's an awful lot of things that need to be done around culture, around organisation, and around governance. So it's complex work and it takes a long time. And local organisations need the support to be able to do that work. So learning from other nations, my research is on developing sustainable remote, rural and coastal healthcare systems. And I think this is something that we can learn a lot from Scotland. So I think what's crucial is clinical leaders, and I'm doing some work with Emma Hoskins at the moment on how we support clinical leaders. And I think this is something that Scotland is doing well and is providing support for clinical leaders, but that is particularly focused on the challenges of remote, rural and coastal communities rather than more generic management support. You know, there's a lot of creativity in rural areas and there's a lot of room for innovation and doing things differently. And clinical leaders play an important role in that because they know the work, but they also know the concerns of people who deliver the work. I'm interested very much I'll be really quick. I'll be interested very much in hearing more about integrated health and social care from Northern Ireland, but also about your approaches to mental health and trauma. And lastly, what we've learned from England and what we're using from England is the human learning systems approach. And this is something that was developed from Northumbria University. And we use it to underpin our partnership working. And what it is it's just a really in-depth understanding of how publicly funded welfare systems work. Will, you look like you want to hurry me along.
I'm sorry. Yes, we're getting.
Okay.
Yeah.
So, I guess what I've learned from moving to Wales is that how we do things is important. And so I wanted to finish on this, which is something we use here in North Wales when we do our partnership work, which is, really focus on how you do things and the importance of relationships, the importance of mutual understanding, and the importance of mutual respect. So the way you get to the future is the future you get. Diolch.
Thank you,
Thank
and
you.
I'm sorry to hurry you along.
I'm so sorry for going over time.
Look, I've some interesting questions in the Q&A here, and I'm trying to kind of it's a kind of theme really, and then a particular question. But I mean the theme of the questions, and all the questions have a slightly different take, is broadly has stability in organization produce better outcomes, and to the extent that it and yes, essentially that. Scotland's been stable, so has Northern Ireland. All this change in England, and yet has it promoted innovation? There's one question which suggests that Scotland might be an easier place to innovate in than England, pointing to the approval for the brain tumor medication for Asdanip. That's an interesting point that we might like to be kind of confronted. So you've all seen each other's presentations. There is a kind of, if you each can speak to kind of 1 minute to that notion, stability versus kind of organizational change, advantages of contractuality and all it brings, and is Scotland more innovative than England? Let's go in the order in which people spoke. So, Ellen, why don't you go first?
Yeah, I can start. I think it's a fascinating question, but I probably would challenge the premise. I think there are no intrinsic advantages of regular structural reorganization. That's expensive, it disrupts relationships, it makes people defensive and antagonistic within their organizations. I think that structural reorganization may be necessary as a means to defined ends. I think from an outsider's view, what we've seen in England is disagreement about those ends and about how to get there. In Scotland, there's been a far greater degree of consensus there, and I broadly think that's been beneficial. It does sometimes perhaps indicate a lack of political courage, I think, is when we look at some of the aspects of the system, structure of the system, that may not be optimal now, especially things like digital working, remote working, which have really moved on across the last extended period. But then the other complicating factor, which I know Kath is going to say, because Kath feels it's very unfair that she only got 10 minutes to talk about 40 million people's health service, and I understand her point, is simply scale. I mean, the specifics for why the SMC approved that drug faster than NICE, I don't think is probably something that makes sense to go into just now, but scale is scale and simplicity of organisation makes an organisation easier to collaborate with, is my kind of soundbite answer.
Anne-Marie?
Hi. So yes, I would definitely have to agree with Ellen that too much structural integration is very unsettling. And I think speaking from the Northern Ireland experience, that's particularly the case if it's not underpinned by a clear strategy that tells people what is going to be the result of that integration. And I think the work here has shown that it's been particularly unsettling for staff, staff in those frontline roles who are continuously seeing this reorganisation from the top without any real clear justification for that.
Yeah, so what I'd say about England, I think that's really interesting, Anne-Marie. So what I'd say about England is I think that yes, I mean obviously we've been hyperactive in our our reorganisations, and it's a problem. Of course, it's a problem. I think nobody would say that structural reorganisation is a good thing for its own sake. What we found in our research is that historically, people on the ground have been very good. I mean, I think there's lots of similarities with Wales actually, in that in local areas in England are very good at collaborating together. You've got people who've been working together for decades, who know each other very well, and where they just basically flex around whatever the structural changes that are happening. I think the problem we've got at the moment, and this is something that I do feel, is that we have a little bit of what matters to me, what I think does matter, is about decision making and accountability, because what slows decision making down is not knowing who's responsible. And I think that the ambiguity we've got at the moment around the 10-year plan is around how local decisions are going to be made, because as Ellen pointed out, ICSs are very big, and you said 1 million for the biggest is 3 million. I mean, that's huge. And that can't make decisions about local service delivery. So responsibility has to be devolved below that. But at the moment, we don't know how that devolution. We don't know which structures below that level are going to be making those decisions. And I think that's where I'm concerned, because I think that local people on the ground are very good at maintaining their relationships through structural reorganisation, but you have to know who's responsible for what. And I think that's the problem. That's where we are at the moment. I think innovation, I don't know. I genuinely don't know, because actually one of the things I think is the NHS we need less innovation. I think we just need to do the basics better. I'm not an innovation enthusiast. I think we just need to do the basics better, and stop pretending that innovation is going to save us.
While you're on, there's a question here about workforce planning, which is deemed to be pretty damn poor in England and getting worse. Perhaps better in Scotland. Any reflections on that? And then I want to come to Lorelei. Kath.
Workforce planning. I mean, I don't know what it's like in the other nations. I think we have been very bad at it in England. I think we did, possibly driven by NHS England when it's sort of autonomous, when it was being very autonomous, was that we got an absolute dash to kind of massive skill mix change with lots of different types of practitioners doing lots of different things, and I think that was the way that was introduced. The Leng review has shown us that the way that was introduced was problematic. I think workforce planning is really hard. But I think Lorelei's right, that I think we need to, that the job satisfaction is a real problem, and I think that all of the nations in the UK are going to struggle if we can't improve retention.
Lorelei?
In defence of innovation, I would like to suggest that what I was talking about with new models of care for older people is absolutely essential. I think we really do need a new way of working to care for older people in the future. Else, what are we going to do? We can't keep going on with the current system. So, in terms of innovation, what the research shows is that you need collaboration, you need trust. That is what gives you creativity, and that's what gives you durable innovation. And it's when those collaborative networks get disrupted by reorganization, but also disrupted by, I think, hierarchies. And in England, you get a problem of having very coercive management hierarchies with a singular focus on finance. And that can disrupt a lot of the work around collaboration, which is essential for innovation.
A question here from Nina Hemmings about how funding and provision of community health services compares across the UK. Anything that England could learn from Scotland?
Can I just say something on that from the English perspective, from around the contractual issue, because I think that is really important, because the big problem we have in England is because we deliver everything by contracts, which isn't in itself a problem, but actually the problem we have is that acute contracts are by and large paid for activity, payment for results, and community contracts are block contracts. And that's introduced quite a big distortion in England, that it's very hard to move money into the community because the acute contracts, which is, and paying acutes for activity is a really good way of getting activity out of acutes, and therefore that helps with access, and it helps with waiting lists, etc. But it does make it very difficult to move money around, and I think it's probably easier to move money around in the other nations.
And just quickly from the other nations, do they want to speak to that? Is that Anne-Marie, Ellen, is that your experience?
I think.
I would be
I'm sorry,
amazed.
go ahead, Ellen. Go ahead.
Sorry, Anne-Marie. I was
No.
just going to say, I would be amazed if Scotland had anything to learn on data, anything to offer on data. My understanding is that our data is not yet very good, but I'll let Anne-Marie speak more.
No, I mean, I was going to say the same thing. Adult social care data in particular is really poor. There is much better data on children's services. There's a big focus now on developing much more substantial adult care data. I think what I would say is that the funding of community services is, because of the integrated structure, I think, contrary to what you might expect, has been probably slightly easier in Northern Ireland than in some other places, that community social care services have been able to, fight for some of that budget and to spend some of that money really quite well.
We're going to wrap up in a minute, but I just want to kind of throw this open to all four of you. I mean, you've heard the presentations, you've seen the questions in the Q&A. Is there anything that you would identify that from which other nations could learn, either as a do or as a don't? You've got a minute in which to kind of collect your thoughts.
I would really say from a Northern Ireland perspective, the real weakness around public engagement has been a real barrier to progress. And I think we can learn from the other three nations around that. And I think the most recent documents do indicate that government has learned that message. There's much more effort now going in to explaining, what government wants to do, how it's going to happen, and why it needs to happen.
Thank you. Kath?
Yeah, do's or don'ts. It's hard to. Well, we're about to abolish Health Watch, so we had quite a good system of public engagement, and we're changing it already. I think. I'm not sure that I think the contractual thing is really interesting, and what I'd like to do, I think, rather than doing a don't, I think we need to learn. I think we need to really look at, is integration via contracts better or worse than integration from other, but done in other ways, and we genuinely don't know that. And I think that'd be, because I think we all want integration, we all want better collaboration, and I genuinely don't know whether which way is a better way to do it. And I think that's something we could learn from cross-country comparisons, and that's what I'd like us to do next.
And before I wrap this up, is there anyone want to speak to Kath's point? Ellen, Anne-Marie, Lorelei?
I think we should absolutely fix the lack of cross-national learning that's happened in the UK, and I'm sure we'll all be very much in agreement with that. I think the funding structures have really mitigated. Some of the big funding structures have not been cross-national, and I think that's really hampered, and it's just a big missed opportunity for our ability to learn from each other's experiences.
Well, look, we're now at 2 o'clock on the nail. So I'm just going to say a few concluding remarks. First of all, very engrossing, and that kind of issue about contractualization, integration, reforming a lot, reforming hardly at all, having any relationship to performance, sits there as a kind of open question at the end of this. I want to thank the panel for being so kind of articulate and doing it and the presentations in such short time. Thank you. And thanks to the Social Policy Association for partnering with us. Do look at the Devolution Hub on the Academy website. And there's a recording of this panel will be available there, I think, quite soon. There's 2 more events to kind of put in your diary. 21st of April, what can devolved governments do to address the cost of living crisis? And the 28th of April, what to do about child poverty. And Ed and Steve will circulate details of those two events. Um, Thanks again for tuning into this. I hope you found it interesting. It's a well worthwhile way of spending 60 minutes and picking up a lot of information in double short time. So thank you all four panelists. It's really great. And I thank the audience for attending. And I think that's all from me. I think we can wrap it up. So um, that's a wrap, as we used to say in television. Thank you so much, everybody. Thank you. Thank you.